We're going to be two radiation oncologists to present our project. So, my name is Tarek Hijal, I'm a radiation oncologist at the MUHC. Et James, c'est un radio-oncologue aussi, clinicien, chercheur, dont la recherche est sur l'intelligence artificielle. Après avoir fait une maîtrise au MILA, il a été recruté par notre service pour vraiment développer l'intelligence artificielle en radio-oncologie. On va vous présenter 3 projets qui sont en cours dans notre service et pour vous montrer qu'est-ce qu'on est capable de faire en IA et radio-oncologie. Merci, James.
Si je vais me présenter, mes excuses tout de suite parce que j'ai une autre présentation à faire en fait dans 15 minutes. Donc, je vais seulement présenter les 2 premiers projets, puis par la suite, je dois partir. So, I will present the 2 first projects because I have another presentation that I have to run to, literally. So, thank you very much. It's an honor to be here. So, we at the Radiation Oncology Department, we are very much bought into the power of AI and how to leverage that in terms of 2 big pillar, one of which is the decision, so personalized medicine. The other one is for workflow. So this is what we'll be presenting today. So in radiation therapy, one has to understand that it's an entire workflow. It's a very long and complex workflow processes that include many sequential steps, all of which combined takes quite a lot of time. But there are many areas where you can actually make it a lot more seamless and easier to work with. So we start with consultation, we simulate the patient, we do the contouring, we do the radiation planning, we do the delivery, and then we follow the patient. Now there is a role for AI in all of these steps in the continuum of care, and it's becoming very, very complex. And to improve safety, improve efficiency, and mitigate the lack of resources, there are many ways that AI can come into the picture. Okay, so let's reimagine the entire consultation process. Now, as you all know, and auto-segmentation and side effect triage, you all know what ChatGPT is. Now, ChatGPT is a large language model. You could actually leverage a lot of the large language model capacity and capability to actually understand all of the medical files that you have on your dossier. Now, a lot of the time in physician time is spent actually for us just trying to figure out where I can get the information on your dossier. 49% of the time is actually spent just looking at the screen instead of actually talking to the patient. 27 of the time, only 27 of the time is spent with the patient. And after that, I have up to 36 minutes of charting per patient. So how can we change that? So retrieving, synthesizing, integrating medical data, patient visit, and now I'm not even touching the thing and it's moving. All of that can help you produce your report even before seeing the patient. And that would mean a lot of time saved staring at the screen and a lot more time with the patient. And the metrics are huge where we could actually save time. We could increase patient throughput. We can actually decrease or actually identify these patients before going to the ER. We can spend more time with the patient, and more importantly, because already leverage AI, we can use that to adhere to guidelines. Second project that I would want to talk to you about is my personal favorite, auto-segmentation of lung tumors. Now, lung tumors can be treated with radiosurgery. Radiosurgery is an extremely precise way of delivering radiation therapy only to the tumor that you want in the lung. So this is just a depiction of what it can do. Now, normally when you want to train a model to be able to contour the lesion that you want to treat, you need a lot of data. Every single institution have their own data, but it's limited to our own institution. In the last couple of years, between 2019 to 2023, we have seen a large increase in patients requiring this treatment. Unfortunately, we don't have the resources to treat these patients, so there is a lag time. And the reason why the treatment, patient seeking treatment is increasing is because of better systemic therapy, patient living longer, and more precise technology. So how do we actually make sure that we can give treatment to all of these patients? How do we improve access to all of these patients? One of the projects that we're working on right now is to auto-segment the lung tumor, which normally takes 2.4 days to treat. Now, during that time, the patient is actually doing nothing. It's just waiting for us to finish our job. Auto-segmentation is something that we do currently already for organs at risk in our hospital, in our treatment strategy. It has not been done yet in tumor, but it is happening. So, in order to train this model, we don't have enough data, but other institutions have these data. Now, because of confidentiality law, we cannot share data. So what we have been doing is use a federated learning methodology where instead of sharing the data, we're sharing the models so that the model becomes much better and being able to work on a larger population. It's really feasible. We have the AI expertise. We have the federated learning worked out. We are collaborating with other institutions. And we have the capacity. Doesn't take much, just a tiny little GPU to do that job. The return is amazing. So between MUHC and Chaudière-Appalaches Hospital Network, we treated 430 patients last year, all of which has 2.4 days of wait time, dead time, not doing anything. Now, federated learning with the auto-segmentation has the capacity to completely do it instantaneously, leveraging 1,032 days, work days, per year. Doing so, we're building AI expertise across the centers in radiation oncology in Quebec. So we're building AI expertise locally as well as provincially. And it's scalable. We could scale it to virtually any other organs that we wish to treat. And we can also very easily scale it up to all the other institutions who wish to join. It's as simple as downloading the model and putting the pipeline together. Unfortunately, I have to leave, so I will leave it to Dr. Tarek Hijal to continue the rest of the talk. Thank you.
Thank you, James. Thank you, James. So we'll finish with the last example that we want to put in place is the symptom and side effect triage hotline. So that's the third star in our pathway in radiation oncology. When patients finish radiation, they often develop side effects 2 to 4 weeks after the end of treatment. And it's very difficult to catch these patients. They're back home, they're not with us every day, but they're experiencing side effects. We have very few resources. We don't have the capacity to answer the calls of everybody. We do our best, obviously, but it's quite difficult. So that's where AI can help us with an automated symptom triage hotline. So what's the idea is that our systems, everything is electronic in radiation oncology, know for every patient their contact information, what type of radiation they got, when it's gonna end, and we can program when are their peak side effects, so when they should be contacted by the triage hotline. And at that point, according, like we said, to the diagnosis, the volume of the radiation, the dose, they would then be contacted by the triage hotline. So, and the hotline could easily, automatically assess the symptoms. Obviously, this is where the medical legal things come in place, and you need, maybe the first step is to think about triage according to what the patients say, triage according to risk. Maybe give it a green, yellow, or red, and then send a report to the treating team in terms of the urgency, in terms of the color, and the report could actually tell you what the patient has, and even what the actionable action item is, because we can feed these algorithms with our own treatment guidelines, so it can tell us what to do. And so that's the third example we wanted to present. And what metrics would we measure? Patient access. Are we increasing the access to post-radiation care to our patients? How their satisfaction is with these tools and their visits to the ER. You might have noticed that all the pictures in here were actually produced by AI. And I wanted to put that last one because, for a specific reason, AI is not yet la panacée. So there's still a lot to be done. You see, the program I use knows I'm at the MUHC. I fed it a lot of stuff, including the Cedars Cancer Center. And the logo of Cedars doesn't come like the logo we know. So there's still a lot of work to be done for the technology to be where we want it to be, but we need to be the leading edge to start this kind of work. Thank you very much.